Hello, today I'm going to cover the chapter on diarrhea. Diarrhea is one of those symptoms that I think doctors don't really like to hear about and patients don't really like to talk about. But it is a very important symptom and can be a sign of an important uh, disease. So it's important to go through it. You should be aware that diarrhea can be disabling and lead to social isolation in many patients. So it's important to try and solve the problem or at least ameliorate it if possible. What is the definition of diarrhea? The definition of diarrhea is you're having more than 3 bowel movements a day and they are not completely formed and they're a change in bowel habit. That's typically how I think most gastroenterologists look at it. We used to have a definition in gastroenterology having to do with weight of the stool, but that's gone by the wayside, I think. There's a lot of diarrhea that is very temporary, may last only a week or two, may be viral in cause, could be from norovirus or some other virus that has caused the problem. So not all diarrhea is worked up, but it simply resolves in a lot of patients. There's also what's known as a Bristol stool scale, which defines diarrhea having to do with a scale of 5 to 7. So number 5 is where you have soft blobs of stool. Number 6 is where you have fluffy stool with ragged edges, and number 7, no form stool, everything's watery. So that's considered diarrhea if you're using the Bristol stool scale, which is readily available online. So in a large series, it was found that in the United States, about 3.5% of patients have chronic diarrhea, no constipation. 9% have alternating diarrhea and constipation. There is a tendency in practice to shrug off diarrhea and reassure the patient that everything is okay, but nothing really gets accomplished there if the diarrhea continues. There are a lot of people that live with diarrhea and they don't seek evaluation and don't get evaluation and don't get resolution. And as I mentioned previously, can be disabling and socially isolating and a big problem. Can also lead to nursing home admissions because the family's not able to take care of the patient at home due to diarrhea. There's a tendency in practice to label everybody irritable bowel syndrome because it's a term that people are very familiar with and they accept that term, and then they go home and they tell everybody they have irritable bowel syndrome, but nothing really gets accomplished there except a lot of chit chat. There's also a tendency to do screening colonoscopy, which is usually reimbursed in full by medical insurance, and call the patient irritable bowel syndrome, and you didn't find anything. We didn't find anything. Everything looks okay. But in chronic diarrhea, which is diarrhea that persists beyond 4 weeks, you're supposed to do biopsies of the lining of the colon, even if it looks normal, looking for inflammation under the microscope, so-called microscopic colitis. So instead of a screening, you're supposed to do colonoscopy with biopsies throughout the colon, taken through the scope, these little pinch biopsies of the lining. And that may not be done, so that if the problem continues, and I've seen this happen before, patients come in the office, oh, they had their colonoscopy, so, oh, that's great, let's look. And you find out they didn't do biopsies. Well, you don't know if they have microscopic colitis or not, and it's important because the treatment is different. There is a treatment for microscopic colitis in terms of medication. So the workup then that I usually did was done in a stepwise fashion. Now, if you go to medical meetings, they will focus in on cost containment, meaning don't run too many tests. Let's do just a few tests and see if we can solve this. There's nothing wrong with that, except it oftentimes doesn't work in some patients, and so the patient may need more of a complete evaluation, and it's usually done in a stepwise fashion. The downside of that is that patients will tend to lose their patients over time and they don't come back. So you may only have a certain number of tests that you can do in the patient, or it could be that they'll do those tests and then won't come back for a while, and eventually then they'll come back. But when they come back, you hope that the previous tests are still something you can rely on and you don't have to repeat those. So I generally had a stepwise approach. I would do a colonoscopy with biopsies. If they had any upper tract symptoms at all, I would do small bowel intestinal biopsies with an upper endoscope, looking for celiac sprue. Otherwise, you can do blood tests for celiac sprue. I would do breath tests for lactose intolerance. We had a breath test for fructose intolerance for those people who are drinking a lot of soda, such as Mountain Dew seems to be one of those that has a lot of fructose in it. And then I did a breath test for bacterial overgrowth, and that occurs as well. We get too many bacteria in the small intestine, not the colon. The colon has bacteria in it. So we had a series of 3 breath tests that commonly we would do, looking for those conditions. And a lot of people had more than one problem going on. They had lactose intolerance and they put up with that. Then something else came along and just made the diarrhea intolerable, and that's when they came in. So they may have more than one problem going on. Stool studies may be important. There's a lot of food poisoning going on in the United States and elsewhere. And if you follow the news, you'll see there's outbreaks of salmonella, there's outbreaks of Giardia, there's outbreaks of a number of different pathogens that can cause diarrhea. E. coli is a big one. Listeria is also a big one. And so these bacteria will show up in our food that we eat, and there'll be recalls having to do with that. But before that happens, a number of people will get sick or ill, be in the hospital, and some will actually die. From salmonella in particular, I can recall those. There are cases of Vibrio from raw oysters or other food items that can be fatal in certain patients, such as diabetic patients or patients on immunosuppressives. So those are important to remember. There's medications that need to be reviewed. Metformin is a common cause of diarrhea. It's dose related, famous for causing diarrhea. There's drugs like Zetia, which are used to control cholesterol that cause fat malabsorption. Well, those can cause diarrhea. Xenical, some of the diet pills can cause fat malabsorption. They cause diarrhea. They used to have, and I don't know if they have these anymore, I don't think I've seen them, WOW chips, W-O-W, WOW chips. Well, they had a fake fat in there. Would turn your stool orange with diarrhea, and I remember seeing a patient about that. I had a patient on chronic Plaquenil, and she was getting diarrhea as well. It really wasn't until that medication was changed, not for diarrhea problems, but for other reasons, that her diarrhea came under control. There is a medication that's used for vascular patients called Silostazol that can cause chronic diarrhea as well. And there's many medications that can cause diarrhea and many antibiotics as well. And if the patient's been on antibiotics or in the hospital recently, it's a good idea to check the stool for Clostridium difficile, because We're seeing a lot of that in the United States, C. diff, diarrhea from a toxin that the Clostridium bacteria produces, and it's been a major issue. So that's important to look at as well. Now, other causes of diarrhea certainly include celiac disease, and this is a popular one with patients. They like the idea of having an unusual case of celiac disease they can talk to about their friends. And one of the experts in celiac disease that gave talks about that used to call them celiac wannabes. So it's important to check for that. Basically, you can do blood testing, antibody testing for the gliadin and the endomysial antibodies that are characteristic for celiac disease. You can also do biopsies of the small intestine. Food allergies can certainly cause chronic diarrhea. Elevated eosinophil count in the blood, elevated immunoglobulin E or IgE in the blood is a clue. And of course, a dietary history may be helpful. There are some patients that are taking laxative surreptitiously or on the side, and they can certainly have diarrhea, and you may not be aware that they're doing this, and they may have to be asked specifically, and even so, it may be difficult to know about that, and there's some stool testing that may reveal such a problem. Magnesium can cause chronic diarrhea. Patients that are on milk of magnesia, they're on magnesium supplements, they certainly can cause diarrhea. And it can be important to figure out, okay, when did the patient start this medication? When did the diarrhea start? Let's stop the medicine for a while, see if the diarrhea goes away, and go back on it. Diarrhea comes back. Well, that's most likely what it is. So other tests, stool studies that are looking for too much fat in the stool, indicating malabsorption. You can look for pancreatic enzyme elastase to see if there's evidence that the pancreas is causing malabsorption by causing too little pancreatic enzymes to go into the intestine. There can be so on that note, I'll mention there are a number of patients that are just put on this and that. Why don't you take some pancreatic enzymes? Well, you really have to take a large quantity of prescription strength pancreatic enzymes to solve such a problem. And you have to figure out why the pancreas is not working. It'd be unlikely to be due to cancer, but certainly it can be due to other reasons. And some patients from pancreatic insufficiency will have diabetes associated as well. So it may be related to that. And you may have to do imaging of the pancreas. So it's important to see if that's really what's going on. It's important to recognize that sorbitol can cause diarrhea. This was a board question in GI having to do with diabetic candy. So you're going to take candy that's for diabetes or diabetic patients, doesn't have sugar in it. Well, they put sorbitol in there and it can give you diarrhea. Sorbitol is added to feeding tube items as well. Patients on a feeding tube, you got to think about sorbitol. And so then you get down to, once you've done your evaluation, some other issues. Before I go there, I will tell you there are a lot of people that tell you that food's going straight through them. What they mean is right after they eat, they have diarrhea. That's not like food going straight through you. Food going straight through you is more like when you have an abnormal connection or a fistula between the small intestine and the large intestine, and food doesn't really have a chance to get absorbed. So a lot of people are mistaken by that. There's a normal reflex in the human body to after you eat, to go ahead and have a bowel movement. So people, when they say that, it most of the time doesn't have a lot of significance. Now, if the patient does have a fistula or an abnormal connection between the small and large intestine, yes, it's possible they could have diarrhea. Also, older people that are ill and debilitated, if they have a fecal impaction, you can have diarrhea stool around a fecal impaction, and that can be a real fooler. And people get fooled by that, and they'll do anything to avoid doing a rectal exam on the patient, but you really have to do the rectal exam to know what's going on. And you have to follow the rectal exam in order to clear a stool impaction, because there's all kinds of people coming by declaring victory because the patient had some kind of bowel movement. But you have to make sure that impaction is cleared out, and you can have what's known as pressure necrosis, where you have ulceration of the lining in the rectum related to a hard stool impaction in chronic debilitated people that are bedridden commonly. Okay, back to diarrhea treatment. So finally you get into the treatment phase, and there's a lot of, I think, misguided approaches that can go on here. So a lot of times doctors will tell the patient, well, why don't you just go ahead and go on a gluten-free diet? Okay, well, gluten intolerance, not celiac sprue, can cause diarrhea. So patients may then try to avoid gluten and may have a positive result. But it's not an easy diet to accomplish. They certainly need to be checked for celiac sprue, because you have to be very diligent if you have celiac sprue and following a gluten-free diet. On the other hand, if you just have gluten intolerance, you may be able to tolerate a small amount of gluten without problems. Also, a gluten-free diet, there's been some concern about heavy metals that are in a gluten-free diet, and that's an issue I think that's still being looked at. Nevertheless, it's still commonly given to the patient to try, but I never really did that because I think that's a difficult diet to follow, and you really want to know what the diagnosis is. And people don't do things that are difficult or things that are hard to keep up without really knowing that they need to do that you have a diagnosis. There's also the FODMAPs diet. So the FODMAPs diet for irritable bowel syndrome, where you eliminate various food substances, and I always have to look it up, non-fermentable, such and such, and so on. So that is also a difficult diet to follow. It is easier if you eliminate the possibility of fructose and lactose intolerance. It becomes easier, so the breath testing can be valuable there. I generally have not asked people to go through that diet. If you do the breath testing for bacterial overgrowth and the patient is positive, antibiotics, rifaximin is a common one that was used, or Xifaxin is the other name for it. And that can be helpful, and you may have to treat the patient with antibiotics like that intermittently. But I do not recommend that it's done empirically without doing the breath test, because again, even though the breath test is not perfect, the patient really and the doctor really will have doubts about what they're doing without really nailing down the diagnosis better than that. Now, beyond that, I usually, if I have no real clear answer and the patient is strictly a diarrhea patient, they're not really alternating diarrhea constipation, I will try them on Imodium and pick a dose and then adjust from there. Lomotil is another drug that can be used that way. Also, patients can get diarrhea after their gallbladders are removed, and so there's specific medicines for that are called bile acid binders. Questran was the classic one for that, but there are newer ones. Part of the trouble with that is they can bind your other medicines, so you have to be careful when you take them. Tricyclic antidepressants such as Elavil, amitriptyline is the other name for that drug, can be given at nighttime to try to control diarrhea. It does tend to cause dry mouth and can promote weight gain, at least in higher dosage. And the dose that's given to control diarrhea is not going to provide antidepressant effect. Alocitron was a drug that I was a primary investigator in here in Virginia, and I didn't see a problem with it. But there is associated what's called ischemic colitis, that is an area of the colon that doesn't get enough blood flow that has occurred with the drug, and there have been lawsuits, and so it was restricted in terms of who could write prescriptions for it. But a similar drug, Zofran, may also provide some constipation or help correct diarrhea. And so Zofran is one that's more commonly available, and there's been less risks associated with that drug. So if you might give that a try. There are patients that will tell you what medication that they've taken in the past that helps them with diarrhea, and you can use that history as well. There was and is a drug called Viberzi that was developed for diarrhea patients. There are restrictions, though. The patient cannot drink more than 3 drinks a day of alcohol. They cannot have the history of having their gallbladder removed. They cannot have a history of pancreatitis or liver disease. So I think those are the usual things that are available for diarrhea patients. Now, for the patient who has alternating diarrhea and constipation, fiber may be helpful there in trying to figure out a regimen for the patient that works. I think then if the patient gets diarrhea but they know they're going to have constipation next, you make minor changes, and that can be more difficult to treat or deal with. But with a careful history and careful use of fiber products and eliminating lactose intolerance and those types of issues, you may be successful with it. Also, it helps if you can solve the diarrhea part of it, then you can work on the constipation with the medications that we have, and it'll make it easier to solve that issue. And you have to remember that irritable bowel syndrome is defined by having pain. If there's no pain with the patient, then they do not have irritable bowel syndrome. They may just have chronic diarrhea or chronic constipation, what's known as chronic idiopathic constipation or cause unknown. So with that, I think I'm going to go ahead and conclude. Well, before I conclude, there are a few other things I'm going to mention. In the hospital, it's important to remember sorbitol, Clostridium difficile, and look at the medications. A lot of times patients have been on antibiotics. You can have antibiotic-associated diarrhea, but it's not C. diff, or it may be C. diff, and certainly eliminate that possibility by checking stool studies for C. diff. There are also patients that chronically consume alcohol, but they don't admit to it, and so if you have a patient who is really consuming a lot of alcohol, they can get diarrhea, and that can be a real fooler. I've been down that road before. I'm going to mention pasteurization. There's a reason we have pasteurization, and it has to do with eliminating bacteria like Listeria. Was developed also to eliminate tuberculosis, which cattle had, and a number of pathogens. And so when patients are drinking raw milk, that's a mistake, and it's one of the riskiest things that a patient can do, and it can cause major problems. And the same thing applies with raw cheese and raw apple cider. Raw oysters are associated with hepatitis A, norovirus, and a number of pathogens that are to be avoided. Raw fish, you can get a parasite called Diphyllobothrum latum, which would also cause B12 deficiency. And so raw fish can be a problem as well. So there's a reason why we cook our food and pasteurize our milk products. I want to keep that in mind. And with that, I'm going to go ahead and conclude the talk on diarrhea.